Welcome to Wellness Woodbridge. I'm your host, Ann Mazza of Vito Mazza Salon and Spa and Hair and Scalp Wellness. And today I'm here with Dr. Jessica Mann. She is a reproductive specialist, and we're going to talk about reproductive health. Hi, Dr. Mann. How are you?
Hi, Ann. I'm very well. Thank you very much.
Thank you so much for coming in and talking with us. This is a very prominent wellness issue, and it's something we've never talked about before, so I'm very excited to share that with our TV viewers at home so we can maybe give them some tips if they're ready to start a family.
Yeah, I'm very, very glad to be here. Thank you so much for the invitation. It's a topic that is obviously very dear to me, and it's my passion. So anything that I can do to help and inform patients, I'm here. Thank you very much.
Wonderful. So you have clients. What would you say your age range of clients is, people who come to seek your services?
Well, most are women of reproductive age, so pretty much anyone over 18 and up to 45, 50, really. So it really is anybody that is looking to have a baby.
Wonderful, wonderful. So what would you say if our viewers at home are maybe looking to start a family, maybe they are having some difficulty, when would be a good time to say that, they need to seek out some professional help?
Yeah, and that's a very good question. A lot of patients sometimes feel that if their periods are regular, just when we're talking about women, then they need to wait a year because this is the standard of care. However, there are times that if your periods are not regular or you've had a history of surgery, you've been diagnosed with endometriosis, then the discussion needs to happen maybe a little earlier because it's not so straightforward. And so I feel that for a patient who's under 35, if things are completely normal and there's no risk factors, really we could wait until a year of trying to conceive. However, if there's anybody that has a doubt or questions, any time is a good time. Because the fact that a patient comes to my office to discuss their concerns doesn't mean we're going to do something necessarily. Right. Sometimes we just need to investigate a little bit more, and at times they don't need much other than counseling. So It's really up to the couple.
Would you say that a lot of your patients come to you directly, or are they referred through their gynecologist after a certain amount of time?
I would say it's about 60% referrals and 40% self-referred.
Okay.
And like I said before, under 35, 1 year. Over 35, you really shouldn't wait more than 6 months, because what we know about ovarian and egg aging is that it happens at a rate that's not, correlated to the way we look. So we could look great, we could feel great, but our eggs have a time of their own. So there's something about the biological clock that is a reality. And so for those patients, we like to wait. We don't want to wait until a whole year. We usually recommend that they seek evaluation after 6 months of trying to conceive.
And I guess, with the whole egg conversation comes, maybe some clients have less or more, right? And
Correct.
then some, are they all the same? Do they all look the same age-wise? Or could you have ones that look a little younger, or do they age at the same rate?
That's a great question. And as far as we know, it appears that there may be some predispositions. Some women may have fertility until their early 40s. Some women's fertility declines rapidly early on after their 30s. But we know overall, when you talk about the egg quality, that's something that declines after 30s, more so after 35, and then a lot faster after 40.
Okay.
Yes.
Very, very good. So if a client comes in and you take them in and you evaluate them, what would be your first step in evaluation process?
So, Anne, what we like to do is talk to the patients first, get a good history, and find out where we need to proceed. And whether they have a partner or they don't have a partner, that's also important, because if this is a couple, a woman and a man, that if they're trying to conceive, then of course the evaluation of the male is important as well. We've had situations where we think, and the woman thinks it's always her issue because she was diagnosed with polycystic ovary syndrome, periods are irregular, and they've been becoming a little regular recently, they've been trying, and the partner is young, but we do a semen analysis and the sperm is abnormal, or there's low count, low motility, and so it's important to do an evaluation of both at the same time.
Absolutely.
And so for the male, it's a semen analysis. For the female, usually it's hormonal tests. Usually they have to be done at the beginning of their cycle, so there is something to be said about timing. We want to make sure that they come on day 2 or 3, or for our latest, but 2 or 3 are optimal to check numbers like follicle stimulating hormone. These are numbers that can give us an idea about somebody's egg reserve. And another important marker is called anti-Mullerian hormone. This is also a hormone that's drawn on blood tests, and this can also tell us about somebody's egg reserve.
Wonderful. So the first thing would be maybe blood work to get those numbers?
Correct. And the other important aspect of the evaluation is do an ultrasound. All the patients that come in have a pelvic ultrasound, because at times you may not know that there is something anatomically abnormal. So we don't want to waste time, so that's important. And so we do an ultrasound, and sometimes we have to repeat the ultrasound if there's an abnormality that is seen at the time of the initial visit. Now, I tell patients all the time that what's interesting is that, as people, you can do an ultrasound, let's say, of the liver. And the liver is the liver, changes with probably minimal changes, but we cycle. Women have times where they start, the eggs are very small, and they will recruit one egg, and in the middle of the cycle you ovulate. So obviously the ovary is going to look different, the uterus is going to look different. There's different parts of the cycle that are going to be different, and this is why one ultrasound at any random point in time sometimes have minimal value. So we have to look at it sometimes at different times of the cycle.
Well, it's amazing that you can treat the whole client and look at whatever the specific situation is for the woman and the man who are going to try to conceive. To talk to them about, would you say there's a difference in lifestyle changes, stress, some other things that could happen outside that could be affecting their ability to conceive?
Certainly, and that's part of taking a good history, because I like to discuss any kind of other therapies that the patients use, any supplements that sometimes you may not know but may have a negative impact, because sometimes patients say, my friend took this supplement and it helped them, or I was given progesterone and it helped me. Well, if you take progesterone all the time, you're not going to get pregnant, because hormones are different, and different times of the cycle have to be, there are different levels that are important.
So that could be very well affecting it.
Correct. Yes. And the same goes for the males. If they're taking any kind of either supplements that can alter the sperm motility, the count, or sometimes they may be doing any kind of habits that are deleterious to their well-being, and those are important things too.
Very, very good. And if they are doing those things, like if you had to tweak and change them, would it be something that could happen in a month's time? I guess depending on what it is. But, obviously if it's the men, hot tubs, things like that, does that really affect the sperm count?
That's a great question. And it can affect sperm parameters. So things like hot tubs and hot saunas and baths, or a history of surgery, inguinal hernia repairs. So these things that patients may not think have an impact on their production of sperm certainly do. So now, in terms of when would you expect a recovery, for instance, anabolic steroids will make someone infertile. Like the man will have no sperm count, and we know that, we see it. And so when we tell the patient stop the steroids, we would see a recovery of sperm in about 3 months.
Okay.
This is because the sperm life cycle is about 3 months. So you could see an improvement after 1 month, and it could be up to about 3 months. That's when you should see the full recovery if somebody stops using anabolic steroids.
Wow. So you really only need one sperm to make this beautiful baby.
Yes.
But I guess you need a good amount of sperm in order to get an optimal result.
Correct. And it's amazing because a man has to produce millions of sperm so that hopefully one of them makes it to the fallopian tube. So it's a long trek that it has to get to. However, because of this track that it has to get to, you also need to look at the uterus. Is the cavity okay? Are there any problems? Are there any polyps? So there's the evaluation of the uterine cavity for the female is also important. Mm-hmm. Are the tubes open? If somebody's had an appendectomy in the past, that's surgery, and the appendix, it's on the right lower quadrant, so this is where an ovary is in the tube, so they could affect
absolutely
the patency of the tube, meaning it could be blocked because of that, or somebody had surgery for any other reason.
Just scar tissue in general can form, I guess, anywhere where you have a surgical procedure.
Correct. And surgery or any previous infections put someone at risk of having problems with their tubes, having problems with their pelvis. So that's important to evaluate the pelvis thoroughly.
Well, you're almost like a detective.
I am. I love it. That's good you said that, because when I was in high school, they tested that I was supposed to be like an FBI agent. So maybe that's, I found my niche finally.
It's part of it, but it sounds like there's just so many factors and, that could affect your ability to have children. And some people don't even think about it and they can get pregnant, but then, there are others that, really work very hard to try to conceive a family. So.
Yes, and I remember there was a professor in med school that said, it's not amazing that it doesn't work. It's like it's really a miracle that it works in the first place.
Sure.
I mean, the egg is only good for 24 hours. Sperm is good for about 72 hours. I mean, timing is just, you have to get it right.
Absolutely.
And for those patients where it's not happening, it really can take a huge toll on somebody's emotions.
Absolutely.
And their relationship.
Well, I think you spend a lot of time, when you're younger trying to prevent pregnancy. Mm-hmm. And then,
that's right.
Then when you do want it to happen, then it can be very discouraging when you're going through that and you're ready to be a parent and it's not working out.
Yes. And, to that effect, like you said, many patients that have waited, sometimes, you are someone who is driven, somebody who's accomplished many things, and at times this is something that's out of your control. And I think it's important for all patients to understand that stress has an effect on your fertility. And I tell patients, I'm here to help you as a physician, as a scientist, but can't forget the other part of it, the holistic part of the patient, and you're a whole person. It's not just science and the blood work that I'm drawing for you, but you have to feel good. Sure. You have to be optimistic about what's going to happen, and that part cannot be forgotten. It's something that needs to be also taken care of.
Well, you hear so many stories. I mean, I know that just in speaking with you, you're so easy and so approachable and wonderful to talk with.
Thank
so
you. Thank
I'm sure
you.
Your clients feel the same way, but I have heard in the past that people who are having trouble, maybe they continue a relationship with you. Maybe it's easier on the second child, that they're relaxed and they've already, or maybe because their body's already gone through this and it remembers. I don't know, but you seem to hear a lot of stories saying that the second time around can be a little bit easier.
Yeah, and we don't know why. I have had patients that we were very close to, not being successful, but they finally tried and it works. They have their baby, so we're like, it's their miracle baby, and they don't use any form of contraception and the period doesn't come, and 3 months later they're pregnant again, and we don't know how that happened, but it can. It doesn't always happen. So of course, patients that have had a difficult time from the beginning, then they already know, and they're more encouraged to come back and restart the process, and it's a little easier for them the second time around, definitely, in terms of they've done this before. They got it. It's easier.
There's no anticipation there.
Correct.
For what could happen.
Right.
Or, they know what to expect, which is great.
Yes.
Very, very good.
Mm-hmm.
We'll be right back.
Take a look under your bed. find stuff under there? What about jobs? No? Now try your closet. Still no jobs? Just more stuff? Well, you really have both. See, stuff is defined as household articles considered as a group. Sometimes this stuff is no longer needed. Wait, no longer needed? That can't be right. Because remember those jobs you were looking for? Those are really needed, and they're the stuff inside your stuff. Our job is to unlock those jobs, and it starts when you donate your stuff to your local Goodwill. Here's how we do it. When you donate to Goodwill, we sell your stuff to provide job training for people right here in your community. So just by teaming up with Goodwill, you help create jobs. And isn't that worth parting with the leftover keytar from your 80s cover band? Goodwill. Donate stuff, create jobs.
We're back. I'm talking with Dr. Jessica Mann. Dr. Mann, you're also located with me in the Raritan Bay building right next to the medical hospital in Woodbridge. What floor are you on for services?
We are on the 3rd floor.
Excellent.
Yes.
Excellent. So very convenient location, as we have said to the viewers before, convenient to everywhere in this central area. Easy to get to between Route 18 and Route 9.
Lots of parking.
Excellent. Do you need a referral to come for your services from your OBGYN, or can you just come and see you directly?
You don't need a referral. I mean, we see patients that come because their OBGYN sent them to us, or they were self-referred, or they spoke with a friend who had a similar problem, and so it's not necessary to have a referral for an evaluation.
And are your services sometimes covered under insurance, or is it usually out of pocket?
That's a great question, because many patients feel that they cannot come and discuss their options for the fear of being infertility, and this is something that may not be covered by insurance. The one good thing about New Jersey is that we have very good insurances, and many of them actually cover services that are treatment, not just diagnostic.
Oh, wonderful.
Many insurances cover diagnostics, and some, like I said, will cover treatments, including IVF.
Wonderful.
And so this is really dependent on each insurance. We like to make sure that our patients are aware of everything the minute they walk into our office, so that they feel comfortable. And so we usually take that information, and the staff is able to give them the feedback so that they have an understanding of what to expect.
Excellent. That's great. I feel like that's come a long way,
Yes.
I guess, in the last 5 years
Yes.
with fertility. So that's great news.
Yes, and our state, like I said, we are very lucky, because in this state, some insurance can cover up to 4 cycles of IVF.
Wonderful.
It's called a mandated state, and some other states like Connecticut covers 2, but there are many states that have no coverage at all. So we
Okay.
are very lucky.
Very good. We're in the forefront there.
That's right.
So you do help some clients who are undergoing cancer treatments also, and would you like to speak a little bit about that?
Yes. So sometimes patients have a diagnosis of cancer, and obviously that's unexpected. Often young women who have breast cancer or any kinds of cancer that would undergo chemotherapy treatment. Some chemotherapy agents are very detrimental to their egg reserve, regardless of the woman's age. Mm-hmm. And so in these patients, what we know now is that harvesting the eggs before the patient undergoes chemotherapy can give them a chance of having a baby.
Oh,
and for some people, having a child is part of having their life. It's not the be-all, end-all for everybody, but for some women, this is important.
Absolutely.
And for not just women and men, it is something that needs to be discussed. The reproductive options should be discussed prior to anyone undergoing treatment.
Absolutely.
It's very difficult for the patients to understand sometimes their own diagnosis, and then to have to make a decision as to what they're going to do with their eggs or their sperm in the future. But it's important to have the discussion, because at times, like I said, some of these chemotherapy agents can render someone infertile. And so at times we are able to beat the cancer and everything is good. The patient gets back to their quality of life, but they can't have a child. And so that's why it's imperative that they discuss the options with the reproductive endocrinologist.
Absolutely. What other types of couples and people are you able to help?
We are able to help pretty much anyone who wants a baby, and that goes to women, same-sex couples, men as well. So this is an area called third-party reproduction, where we can have patients purchase sperm with banks that are FDA approved, so we have information about this available, purchase eggs, and sometimes patients have significant problems with their uterus. This isn't as common, but at times someone may not be able to carry a pregnancy, so they may have eggs, but they may not have the ability to carry pregnancy. A condition called Mayer-Rokitansky-Kuster-Hauser syndrome, a woman is born without a uterus. And so in those cases, they cannot carry, obviously, a baby. And so in those cases, something called gestational carrier can be performed, where we make embryos outside and put the embryo in somebody else's uterus so they can carry the pregnancy.
Okay. Very well. So you're able to help with those scope of services, but you don't necessarily perform them.
Well, we perform the embryo transfers, but we don't do all aspects. So because the field is so varied in the aspects of it that, there's somebody called an embryologist who will actually be able to create the embryos in the lab, and there's a specific facility you have to go to create the embryos. So
you don't have an embryologist that works directly with you, or is it there where you are? Not in your office?
Right,
okay.
Yes.
Very well. So you use your own embryologist to help you, or no?
No. So the embryologist is in the lab.
Okay.
And they are in Livingston.
Okay. Very, very
Yes.
good. So you would get all of the information or anything that you need from the client in your office, or
Correct.
would they ever have to travel to Livingston?
Well, to do the embryo transfer, they would have to go to Livingston.
Okay. And you'll keep track of them throughout the entire process,
Correct.
from start to
Correct.
finish?
Yes.
And at what point do you put them back with their regular OBGYN?
They usually go back at around 8 weeks.
Okay.
Yes. I don't deliver babies anymore.
No, you don't.
No.
But I'm sure they feel so indebted to you, because you do become such a huge part of their journey.
Yes, it's a privilege. That's the way I see it. And everyone in my office is just so committed to helping our patients. So we've been very lucky, to have the trust of our patients and to serve them and to have the babies. So it's this, gratitude is just abounds, really, because it's a great field. I mean, I can't say more. And I think the patients understand that we're here for them, and so it's a nice office.
Yes, without a doubt. I mean, I have accomplished a few things in my career, but I would have to say that my motherhood would be the #1 accomplishment of my life, having my kids and watching them grow and be part of all of that. So to be able to give people that opportunity is certainly life-changing.
Right, and to that end also, like you said, sometimes patients are not ready to have a baby. A woman may be having their career and they may not have found Mr. Right, so then they may want to postpone having a child, which is sometimes a problem if you want to have a child with your genes. Sure. And in those circumstances, we can do something called egg freezing. So we can put a patient through the treatment and then go and harvest their eggs and freeze them. And this way they can use them when they're ready to have a baby that's their genetic child.
Well, it sounds like there's just many options and many little integral pieces that come into play, with what you do. And a lot of that must come from that initial intake where you're trying to figure out, exactly what the issues are or any complications. And then, hopefully everything works out the best they possibly can for your particular client.
Yes. It's important that, we want to take care of the patient first, and the patient as a whole. And that they have a good outcome. And sometimes, in terms of how you approach that, is very patient dependent. I think as a physician, I need to give my patients all the options available and give a recommendation based on their evaluation. However, sometimes patients want to go a little bit faster, sometimes patients want to go a little bit slower, and in some circumstances, it's okay to take a little bit more time. You know, if somebody's 25, maybe the issues are mild, we could wait, but, you know, I think it's also very important for me to tell somebody who is over 40 that I wouldn't want you to wait much longer.
Absolutely. Well, as the professional, I'm sure you're so good at evaluating that and being part of that whole journey for them and figuring out, you know, how strong their sense of urgency is to how quickly you have to move to give them the results they're requiring.
Yes, thank you. And we really want to, you know, take into account that every time a patient looks at a negative pregnancy test, it's so discouraging. So that I think for me, at least as a woman, I understand this is not easy to cope with. And so, you know, when I said to patients, if you're coming to my office, it's because you want to have a baby, therefore I'm here to help you have a baby. So, you know, I want to minimize failure and I want to minimize struggles. You know, it's part of life, of course. It builds character, like people say, but you know, if we try to make the experience the best that it can be for someone.
Well, that's wonderful, and I'm so glad that you're able to give so many people hope and help them reach the outcome that they're looking for. So I thank you so much, Dr.
Thank you,
Mann,
and
for
thank
being
you
with
so
us
much
today.
for inviting me here today. It's been a pleasure to talk to you.
It's so great to have you.
Thank you very
much. And it's
much.
a wonderful topic, and I think it's a topic that a lot of our viewers do deal with in some way or another. So it's so great to get the information directly from you, and I hope that people see you and know that they can come and see you as well at your office in the Woodbridge area.
Thank you, Ann. Thank you very much. Anytime, I'm here.
Excellent. So thank you so much for joining us today on Wellness Woodbridge, and we look forward to having you again soon.